has been an international classification initiative by Dr. Jay Shablani and Francine Burha-Cohen. Involved a lot of retinal specialists, and we were also involved. And it is notoriously difficult to classify different subcategories of CSC. But now, very basically, it's between simple and complex in that classification, and it's starting to be validated. So that would be very useful, because just acute and chronic is by far too much simplistic. So it's a good point. Okay, then we will go to the last talk, and then we can go to the discussion. This is certainly also a controversial topic, the treatment of central serous chorioretinopathy. Can you project the slides, please? Okay. So I think, again, I don't have any commercial or financial interest in the treatment of CSC. But I think, especially in CSC, it's very important to think about the hierarchy of evidence. And of course, randomized controlled trials, and then based on those studies, meta-analyses and systematic reviews should be the mainstay for any treatment. The problem that we have with relatively rare diseases is that there is no good evidence-based medicine in general. So until quite recently, there were a lot of case reports and retrospective studies, relatively small studies in CSC. And this is especially problematic in CSC. Despite the fact that it's common, it is still very controversial how you should treat CSC, because there's a huge preferred practice pattern already in Europe, but even more so in the rest of the world. And still, we need to treat, especially in chronic cases, because it has been clearly shown that there is a risk of irreversible vision loss and a decrease in quality of life in CSC. It is a relatively benign disease, but you all know from the patients that you see that they can have quite a lot of complaints, despite the fact that the visual acuity is still quite okay. So we have to do something about it in quite a sizable proportion of patients. And if there's one slide, and already Elon already alluded to this study, that I would like you to internalize, is this slide. This is a slide from the Vichy trial. This was an investigator-initiated prospective randomized controlled trial on chronic CSC in the United Kingdom. On chronic CSC, comparing oral eplerenone treatment, so a mineralocorticoid receptor antagonist treatment, to placebo treatment. And this slide, interestingly, because I think it's one of the most interesting slides of the whole study, was just tucked away somewhere digitally as a supplementary table. But what it says is the 4-week, 3 months, 6 months, 9 months, and 12-month follow-up of placebo versus eplerenone-treated patients. And here it says complete resolution of fluid on OCT, partial resolution, or no change. Now have a look at what they say. Okay, so there's the placebo left and the eplerenone on the right. It is chronic CSC based on imaging characteristics. And at 12 months, there was a 30% complete resolution, so complete resolution of fluid in chronic CSC in the placebo group, compared to 16% in the eplerenone-treated patient group. So this prompted the authors of the paper to say, okay, there is no role for eplerenone in chronic CSC. It was a very clear statement, and I think they're right. When we look at partial resolution, so a reduction in fluid, but not a complete resolution, was also in 24%. So 54% of the patients have a partial or complete resolution of fluid in the placebo group. Okay, so we need evidence. We need multi-center randomized controlled trials, and they were until recently very rare. The Vichy trial is a very good one. But going back to the pathogenesis, I think I want to shortly reiterate what Dr. van Dijk already told you. We're talking about the problem with the retinal-choroidal interface, an equilibrium between the choroid that is somehow abnormal, that is pushing fluid and maybe other factors towards the RPE. The RPE gets affected, and pachychoroid pigment epitheliopathy can, in the end, in some patients, give a PED, pigment epithelial attachment, and in some cases there will be a leak causing subretinal fluid. There's a disequilibrium between a very overloaded choroid with a thinned choriocapillaris, which can cause CNV because of ischemia, by the way. The RPE pump is insufficient, and then you can get PEDs and fluid. I will skip this because Dr. van Dijk already told you that this is happening. There is a big problem with the choroid. And why is that important? It's important for the treatment, of course. I'm going to skip this because we have to treat this choroidal vascular congestion probably to really treat the root cause of the disease. And that's why we have to discuss this here. Finally, there are some multi-center randomized controlled trials now, and we were quite active in that, and I'm going to highlight them with you. But first, what should be the aims of the treatment? And I want to strongly suggest that you should really go for a complete resolution of fluid, as in this case after PDT. So you see here, there is chronicity of disease, there is an accumulation of the photoreceptor outer segments that are normally phagocytosed, eaten by the RPE, but detached, so they cannot get rid of that. And then after the treatment, in this case PDT, you see that there is a reconstitution of the retina on top of the RPE, but it takes time for the RPE to eat up all the junk that is on top of it. So the patient still has quite some complaints. This is about 3 months after the treatment. The ellipsoid zone is still very bumpy. The ELM is quite okay. And in my experience, in the uncomplicated, not so severe chronic CSCs, you can tell the patient, okay, this will take a few more months, but your visual quality will improve. And why? Well, because the photoreceptors are able, miraculously, to reconstitute their normal situation with the RPE. So you reattach the photoreceptors, they're back into their apical microvilli of the RPE, and that's when vision can improve, unless there is already atrophy of the fovea. So you don't want to be too late with the treatment. And what you would, of course, also like with treatment is to prevent recurrences. And I think you can do that with addressing the underlying problem, the choroid. If you read articles on the treatment of CSC in PubMed, be very careful, because many of the treatment studies are retrospective, and I already showed you, based on the Vici trial, spontaneous or placebo-induced resolution, that they are tricky, because there is a tendency for spontaneous improvement, even in chronic cases. They are highly variable in their criteria. There's a controversial classification, so this is a bit problematic. Now, what are the main treatment options in CSC? Well, many treatments have been described. I'm going to highlight the most advocated ones. PDT, micropulse laser treatment, conventional laser photocoagulation, anti-VEGF treatment, and mineralocorticoid receptor antagonism. And the idea behind PDT, which we all know from the AMD era, where it wasn't very successful, is that PDT is able to remodel the choroid in the case of CSC. So apparently it doesn't just treat a neovascularization, but even more so, it is able to treat the choroidal congestion and the leakage, because you have a thickened, leaky choroid in CSC, which is completely different from AMD, where it's thinned. And you want to bring that choroid towards a relatively normal choroidal environment. They have studied full settings, so full dose PDT, which was very successful and safe in a long-term follow-up Portuguese study. But it has also been shown if you use half the dose, or half the fluence, or half the time. I would recommend half the dose, by the way, because if you are allowed, you can split one vial for 2 patients, so it's cheaper, especially when we have a lack of Visudyne right now, and there's a bit less risk of side effects, so half dose I would recommend. And then there is micropulse laser treatment. And micropulse laser treatment is, I think, a bit mysterious treatment where you would give a laser pulse that is subdivided in smaller pulses, which would then trigger the RPE to pump the fluid away more. The evidence for that is very meager, and I'm going to dive into that a bit more. It would be wonderful if it worked, but I think it's quite mysterious, and it doesn't address the primary problem, which is the choroid. There is still a place for conventional laser, I think, if you don't have PDT, and you have a patient with an eccentric leak, you could treat the leak. Of course, you have a risk of scotoma and neovascularization induction, but I think in that subgroup, and especially when you don't have PDT, you could consider conventional laser photocoagulation, although the evidence is not that hard. Especially there are no good recent OCT and ICG FFA-based prospective RCTs. Anti-VEGF treatment is not the treatment of choice in CSC unless there is a neovascularization. You could try it then. But even if there is a neovascularization, there is often a more important factor of the serous fluid leakage from the CSC background. So you could be disappointed by anti-VEGF treatment, but if you have strong evidence of CNV, I would definitely recommend to try anti-VEGF. And then we have mineralocorticoid receptor antagonists. They have been very popular in the recent years because it's very attractive, right? So CSC is associated with steroids, and the mineralocorticoid receptor is supposed to play an important role. So if we can antagonize that, that might be useful, right? Well, probably not so much, unfortunately. I'm going to show you. But first, PDT versus micropulse. Because we were the first to perform a prospective investigator-initiated, non-industry sponsored study comparing PDT, half-dose PDT, with micropulse laser treatment. And what we did is we used ICGA-guided treatment. So with PDT, we used a large PDT spot. And in the case of micropulse laser, we really painted the whole retina with micropulse laser spots, 810 nanometer. And we compared them with regard to the outcome of subretinal fluid resolution. And what we found was that PDT was markedly superior over micropulse laser treatment with regard to complete resolution of subretinal fluid. The percentage was relatively low compared to subsequent studies. And the reason for that might be, I have to be honest, is that we might have missed some small type 1 MNVs, because it was the time before OCTA. But they all had typical CC background on ICGA. We also saw superiority of PDT over micropulse laser treatment with regard to functional outcomes such as microperimetry, which is especially sensitive to measure macular sensitivity. So we concluded that photodynamic therapy, half-dose PDT, is more effective than micropulse laser treatment, both with regard to anatomical success, so getting rid of the fluid, as with regard to functional parameters. So let's see about the time. Oh, I've got time. And what we subsequently have shown because then people who believed in micropulse laser came to me and they said, well, micropulse laser does work when you have just a focal leak. Then it's equally effective as PDT, I'm sure. We said, well, we can look at it in our PLACE trial, but we have no power to study for that. But let's have a look. If patients have focal or diffuse leakage, does it make a difference? And the answer was, no, it doesn't. Also, in focal patients, PDT was more effective. And then, of course, there were patients who didn't respond to micropulse laser treatment. So what did we do then? We did a crossover in the REPLACE trial. So we treated the patients who did not respond to micropulse laser with PDT, and it turned out to be very effective. So those patients who didn't respond to micropulse did respond to PDT, but vice versa was not the case, unfortunately. And then this study, which is a fantastic study, also investigator, non-industry sponsored study, in the UK, as already alluded to, and in the Vichy trial, as I've shown you, it was clear that eplerenone, oral tablets with eplerenone, was unfortunately not superior over placebo. Actually, it did a bit worse. It was even less effective than placebo, although it was not statistically significant. Unfortunately, it would have been really great if it worked. And we more recently also compared in another prospective randomized controlled trial, also investigator-initiated, half-dose PDT versus eplerenone. We used the exact same treatment regimen as the Vichy trial, so the typical treatment regimen for 3 months. And we found that, again, PDT was markedly superior over eplerenone. Look at the difference. 78% dried up completely after 3 months, compared to only 17%, which is almost exactly the same percentage as in the Vichy trial. And there was also functional benefit in terms of microperimetry in favor of the PDT group. So unfortunately, eplerenone doesn't seem to work. So what we found in summary is that the PLACE trial showed that PDT is superior over eplerenone. Vichy found that eplerenone is not better than placebo. In the SPECTRA trial, we found that half-dose PDT is superior over eplerenone. If you want to read more about evidence-based treatment of CSC, we're updating this. We're publishing a free available guideline in the next 6 months. But this is the one published in 2019. It's one of the most downloaded papers of this journal with a broad range of retina specialists. So there is a consensus on this. You can read more about the treatment of CSC and what we suggest. And there's a treatment algorithm for acute CSC over here, and also for chronic CSC. Over here, we still said that mineralocorticoid receptor antagonists such as eplerenone would be an option. But, well, you can try, but it doesn't seem to work, unfortunately. So why does PDT do the best job? Well, you probably can guess, because it treats the choroid. And that's the primary problem. And it's able to quite rapidly get that fluid away. And it also results in less recurrences. We recently published that in Acta Ophthalmologica. You might think that it's a miracle treatment. Well, it's not, of course. It's not that I think that PDT works for everyone. I've got some really horrible chronic CSC cases that do not respond to PDT or anything else. And there is no treatment option for them. In my experience, you can try everything you want, but there is no treatment option for that. What about the safety of PDT? That's a question that I really often get, right? And on the safety of PDT, because we all have the memory of the AMD era where some patients developed ischemia. But as I already said before, the choroid in CSC is completely different from AMD. AMD patients have a thinned choroid, a sick, thinned choroid. CSC patients have also a sick choroid, but it's thickened and it's leaky. But we have to check it, we have to look at the safety. All the retrospective studies thus far are very favorable in terms of safety. But people also asked, well, can we involve the fovea in the PDT spot? Well, that's nice. We could pool our data from the PLACE and the SPECTRA trial. We looked at that. Patients who had a single PDT treatment, with the treatment spot at least partially covering the fovea, and we had 2 years of follow-up. We used standard half-dose PDT, the settings are here. And what we found that there was a marked improvement of outer retinal structures, also a marked improvement in functional parameters. We just published this paper, it's open access available, and none of the patients developed any atrophy of the ellipsoid zone, ELM, or RPE on OCT and FAF. So you can safely perform PDT. So it's in chronic CSC, PDT is effective and safe. It's, by the way, it's also effective in acute CSC, but I would recommend a watch and wait, unless you have a patient, for instance, who is a pilot or a bus driver and really needs rapid improvement, then you could consider, I would say, PDT in acute CSC. So the key messages of this talk are that the current evidence strongly suggests that PDT is a treatment of choice because of efficacy and safety. Observation can be the preferred approach in first episode acute CSCs, but for recurrent acute CSC, you can consider PDT too. It primarily treats the choroidal abnormalities which lie at the basis, and that's probably the key of the success. And beware of the broad differential diagnosis, but I already told you in the last talk. More treatment options are really needed because all the other options, except when there is neovascularization, are not doing so well in chronic CSC cases and have not been proven. So I really hope there will be more treatments. And attached to that, I really hope there will be better availability of Visidyne, because we are all aware of the lack of Visidyne at the moment. And for instance, in the Netherlands, we still have a relatively good flow of Visidyne. We have a long waiting list. We treat a lot of patients with PDT, but we still have Visidyne available. But I know that the UK, for instance, South Africa, Australia, many countries have a big problem now getting the Visidyne. And the company that is distributing Visidyne almost all over the world is Chepla Pharm, C-H-E-P-L-A Pharm, a German company. They just distribute it. The communication of the company with us as doctors, in my experience, is not that good. But if you don't have access to Visidyne now, you could consider to contact them. And in America, it's Bausch & Lomb. And strikingly, Japan has never had a shortage of Visidyne. Singapore now also has no shortage at all. We are doing quite well in the Netherlands. America doesn't have a problem, but because probably they are the only place in the world where there's a factory for Visidyne. It's made in America, and Bausch & Lomb distributes it in America. So we've got a problem. The access should be more democratically distributed throughout the world. We're working on that very hard. We're also working on seeing if we can open another production line for Visidyne, but it's very difficult, so it will be difficult. Thank you for that, and I look forward to the discussion.
There has already been posted one question in the Q&A. Have you ever noticed CSC post-Valsalva, Camille?
I've never seen CSC post-Valsalva, no. I did have a patient who had CSC after a very rough night, who used GHB, some kind of sex drug, together with Viagra and, well, general excitement, I guess. But it wasn't real Valsalva, I think. But he developed, within 24 hours after his rough night, he developed acute CSC.
Yeah, and we have also let some patients run around the hospital, do an OCT scan before, do an OCT scan afterwards. So it's not actually the same as Valsalva, but after these maneuvers around the hospital, the subretinal fluid had not changed. So maybe that's a bit of an answer to the question. But yeah, the question was directed to Camille Boon, so maybe I'm not allowed to answer. There's another question at the microphone.
One short question. Is there any evidence for micropulse laser? Any sound scientific evidence for micropulse laser? Because we have seen that PDT works better than micropulse.
Yeah.
But is there any randomized trial where they have shown that it works?
There's no high-quality randomized control trial on micropulse laser, but the caveat is that we used 810 nanometer. Now 577 nanometer has been advocated, but there are no good randomized control trials on that really would support it, at least for a first-line treatment. The good thing with micropulse laser is that if you do it well, you don't damage anything. But that's not a reason to do it if it's not effective.
Thank you.
Thank you, Dr. Bon, for the nice presentation. Now we have many cases of chronic CSC in Iraq, Jordan, and also in Egypt. We don't have an access for photodynamic therapy, even the lack of Visidyne. Now, what is the treatment option in such cases?
So if there's no Visidyne available, so no PDT, I mean, I'm sticking to the evidence, right? So then I would think that there's only a case for patients who have one or two eccentric leaks to do laser.
For eccentric, yes, we're using the focal laser.
Other than that, I know that Giuseppe Querques is going to advocate no Visidyne PDT, but I'm very skeptical about that. I haven't seen good evidence to support that. But I really hope, so I don't have a good answer. I want to tell you it's treatment A or B, but there isn't. I hope that Visidyne will be more readily available again. And for instance, if you don't have any Visidyne available in the past in your country, there is good evidence now to support insurance companies to reimburse this treatment. And often it's just one treatment you need and then it's gone and you don't need a retreatment. So you can advocate at your insurance kind of body, whatever you have, to get it reimbursed, because it's more or less expensive. It costs about 1,200 euros, I guess, here to use the Visidyne, but it's a one-off treatment. You're treating patients with AMD with many, many injections that cost together thousands of euros. So what are we talking about? So you could start a dialogue with your governing body about that, based on the evidence.
Okay, you mentioned in your presentation that you're giving the anti-VEGF only for the chronic CSC with CNV or MNV. But in our countries, we're using the anti-VEGF even with the cases without MNV, and also the anti-VEGF works because we are targeting the subretinal fluid. The problem that the recurrence of the subretinal fluid, and also we cannot giving, for example, a loading dose because we are not dealing with the CNV.
Yes.
But at the moment, most of those cases, we giving them the anti-VEGF resolving the subretinal fluid, and maybe later on we're adding the micropulse laser or other treatment. So what's your opinion in these cases?
Yeah, that's good to hear, but I want to go back to the Vici slide. Yeah. So it completely resolves, you say, or what's the percentage? You need trials. Yeah. Because there is a tendency, even chronic cases, and what's acute, what's chronic, to show spontaneous resolution. So it's difficult to interpret those results.
Yeah, but we need to treat at the end.
Sure, yeah. Sure, but do you treat with injections that have not been proven and that also carry risks? I'm not sure. Of course, it depends on the patient. Does he or she want to pay for it? Does she want you to do everything and pay for that? And even if it's not evidence-based and that it carries risks, that's a choice you make between you and the patient.
Okay, thank you very much.
Thank you. Thank you for the marvelous presentations. My question, a quick question about how often do you screen for obstructive sleep apnea in your patients? Do you get a sleep study? Because some of my patients, when I found out they had sleep apnea and they corrected the sleep apnea, the fluid just went away even without therapy.
That's a very good point. Maybe you can answer that.
Yeah, so I know that in literature there are a few papers that discuss that sleep apnea as a risk factor for CSC. We have not conducted larger studies on this topic, but yeah, in literature there's also been said that there's some link between hypertension and CSC. So when a patient has got complaint of that sleep apnea, I think it's good to treat it. Yeah. But I'm not sure if it's the solution for the CSC.
But I think it's a good point. It makes sense, right, that there might be some extra congestion of the choroid, but it hasn't been very strongly proven. But it makes sense to treat it, and it's a perfect way to improve a patient's general health also, I guess. So a very important point. So try to treat sleep apnea and, of course, hypertension, as you mentioned. Yeah.
Well, we don't have Visidyne anymore as well, but we had a patient with a chronic CSC, and the vision was getting low, and we had nothing to do because we don't have, we can't make PDT anymore. So we thought maybe if we give an anti-VEGF, because they thin the choroid, maybe it may work. So we gave aflibercept and it did. Well, it's not the proof. Of course, we don't have RCTs, but just what we found, and it solved the situation, stopped the
there are some reports that
vision.
anti-VEGF also have an effect on the choroid. They thin the choroid, so
Yes.
it does make some sense. The drawback is that you have to repeat it, and probably it's you would need to keep on treating in these young patients because they have a risk of recurrence. So for the time being, you might consider it, but there are no good trials, and it does make some sense, but yeah.
Do you think there is some room for the medical therapy, like ICE inhibitors, like the angiotensin converting enzyme inhibitors?
There's no proof. Okay. That's all I can say. That's a problem in a relatively rare disease.
Either treat and extend or PRN?
Yes, it's a difficult one. Last year I had a talk in the Singapore Society meeting, and the topic was CNV in CSC and how do you treat it. And so I had to dive into the literature, and the literature on that is quite poor. But what was the common denominator is that anti-VEGF monotherapy in patients with a clear CSC background with CNV do not respond super well to anti-VEGF treatment, probably because the choroid and the CSC factor also plays a role. So you could try, for instance, first a loading phase of anti-VEGFs, and if there's no complete resolution or there's a fast recurrence, then I would definitely top up with PDT if you have it, of course.
I wish to share with all of you my opinion. I have a lot of cases for central serous chorioretinopathy in our country, and the vast majority of the patients who does not resolve the subretinal fluid is motivated by neovascular membranes, the vast majority. Then if you look with the angiography for the fluorescein angiography for the neovascular points who leakage fluid under the retina, with the laser, thermal laser in small doses, you can treat the neovascular membrane with good successful. Sometimes very, very close to the fovea, small spots, very low time of exposition, and you can treat very difficult cases close to the fovea with a yellow laser. I'm talking about a yellow laser, but not in micropulse mode, in continuous pulse mode, in regular pulse. You can treat with low power and low exposure. I think, in my opinion, you can do it. Another experience that I wish to share with all of you is that I'm using in classical cases the nanosecond laser, the QRT laser. It's a nanosecond laser who targets specifically the retinal pigment epithelium. In these typical cases, this laser works very good. And in super complex cases with a lot of atrophy, lines of atrophy in the retinal pigment epithelium, you can treat like painting the retinal pigment epithelium with QRT laser, with nanosecond laser, only targets the retinal pigment epithelium and works very well.
Thank you. Thanks. We've got 2 more questions, and then I think it's time.
I wish to know your opinion, if you have opinion about this.
Evidence.
Okay.
Thank you for your lecture. Since we don't have BDT in Palestine, I would like to hear from you, is there a cutoff point of vision and duration of waiting before considering BDT?
Yeah, when you have a lack of Visudyne, I think it would be good to wait at least 6 months if you really. What we did in the Netherlands, we really had a national committee that had to look at every case because we had such a lack. Now it's a bit better. We got a bit more Visudyne, but we had a national committee to look at cases to see, okay, this case is eligible, this is not, and these are the criteria. It should be there for at least 6 months. It should have signs of chronicity. So that's very important, I think, to give all the patients the same access to treatment if you have the option.
And these criteria could be adjusted in the Netherlands based on the number of patients that had been referred to the committee and based on the number of vials, Visudyne, that were available.
So you don't consider vision?
No, vision is difficult in CSC because it's in general quite good. And my experience is if the vision is already poor, what you can achieve is also worse. So you have to treat early in CSC is my experience. The patients who already have poor vision when they present, they do less well because there's less to win, because they already have damage to the fovea. And that often doesn't get repaired when there is already damage done, in my experience. But many have good visual acuity, and the differences between visual acuity are very, very little.
And in the committee, it was the case that if the other eye of the patients was a poor seeing eye, then these patients were prioritized to receive PDT in the other eye.
Yeah.
But did you notice a decrease in vision after the 6 months? If the patient maintained vision of like 6 over 7.5 for 6 months without any treatment, would the fluid affect vision after 6 months?
Well, that's a good point. There are no good studies that suggest that there is a very high risk of waiting for 6 months. That's the good thing of CSC. It's relatively forgiving disease. So it makes sense, right, that the longer the fluid is there, the more damage is done. So in that respect, I would like to treat relatively early on. But there are no good studies on that. So it's a good point.
We need to work on this.
Hello. I come from a country where photodynamic is not available. I think you have just answered part of my question. I'm stuck with the micropulse laser. We don't have photodynamic at all. We are doing relatively well. However, I think it's not just a question of how you treat, it's a question of when you treat. Have you been an advocate of earlier treatment or not?
Well, in the Netherlands, we treat early. I mean, we've treated, like, the last years, we treated 3,000 patients with PDT, and the safety profile is so good. And they respond very well. The patients that do respond, and that's the majority, they are very happy. So in that respect, I have a very low threshold to treat early.
How long do you wait from first presentation?
Well, I work in a university hospital where I see tertiary referrals from other ophthalmologists. So when I see them, they already have disease for at least 2 months in general. So I immediately schedule the treatment because they have to wait on the waiting list too. But if you have a first episode presentation of acute CSC, of course, I would then maybe wait for 4 to 6 months to see if it resolves spontaneously. But if you have a presentation of a patient for the first time, which already has signs of chronicity, so atrophic RPE changes, extensive changes on ICGA, for instance, then I would schedule them as soon as you can, if you have the time and if you have the Visidyne.
So 4 months at least?
In general, you're at 4 months when you treat. But if you have a chronic disease, you could treat earlier.
Okay, thank you.
Thank you very much for your interest in the course, and I wish you a wonderful conference also on behalf of Elon van Dijk. Thanks. Because they are not eaten by the retinal pigment epithelium. So your first start could be, this is chronic central serous chorioretinopathy. But beware, because there is a very broad differential diagnostic spectrum that should be taken into account. And some of them are very easy to differentiate, but some can be quite challenging. And what I'm going to tell you is what we experienced, Elon and I, based on 10 years of experience in getting referrals for central serous chorioretinopathy or something else. It is a very quick overview because there are 13 different disease categories. So if you want to read a bit more about that, there is a free online available overview that we've written, which is about 75 pages long. So if you want to dive into the details, you can read this. And you can use the QR code for that. Why do these patients get fluid in the macula? Well, you probably all know, but it's good to remember that the macula is very different from the peripheral, mid-peripheral retina. Not only in the neuroretina, there are of course more cones, but also the RPE. Excuse me, can you please? Thanks. But also the retinal pigment epithelium is different, the choriocapillaris, the choroid. So it's very important to bear that in mind. The macula and the retina in general is important because you have this symbiosis between the photoreceptor outer segments and the RPE. And the nursing role of the RPE is extremely important for normal photoreceptor function, as you know. And for the visual cycle, it really takes two. You need the start of this visual cycle and the photoreceptors, but then the visual pigment is transported out of the photoreceptor in the RPE and back. So you really need them to work together to have optimal vision, of course. And when there's serous fluid, this is obviously disrupted. It's quite interesting, by the way, why some of those patients with serous fluid still have quite a good visual acuity. But I'll not dwell on that in this presentation. So serous fluid under the macula is not the same as central serous chorioretinopathy. It sounds like an open door, but this is the premises for this talk. So this broad differential diagnostic spectrum really can be split into 12, 13 different disease categories. And of course, the first category, I'm going to quickly discuss some very shortly, and some I will dive a little bit more deeper into. CSC is, of course, the first one we think of. But the second one is very important too, because this is, I think, the most common differential diagnostic entity that you will encounter, especially in older patients. Here is a case of some serous subretinal fluid. What you should look out for is a shallow, flat, irregular pigment epithelial attachment with some mid-reflective changes below it. So in a typical PED in CSC, it's just black, there's just fluid. But here's some tissue, and that's neovascular tissue. Here you can see it on OCTA, but actually on the OCT, if you don't have an OCTA machine, if you see mid-reflective material, very likely there is a type 1 CNV component. And here in this case, you don't see any mid-phase indistinct ICGA abnormalities. This is not the same patient. This is what you see in CSC. This is what you see in a CNV without a CSC background. So if you have ICGA, it's very, very helpful, especially when you have confocal systems, because they can really highlight the ICGA abnormalities. But that's a luxury, I understand. So neovascular conditions are important to differentiate with serous fluid. Look for neovascularization, especially in older and female patients. Vitelliform lesions, Best disease, adult onset vitelliform dystrophy, often filled with some hyperreflective material, but you can also see that in CSC. But it's a very constant phenotype. No spontaneous resolution, at least not on the short term, and no leakage on FFA. Think about vitelliform lesions. Inflammatory diseases, category 4. Those are quite easy to differentiate, of course. Posterior scleritis, Harada disease, it's bilateral, acute onset, very extensive, with also these bacillary layer changes. Quite easy differential diagnosis, but important because you have to give steroids. And you don't want to give steroids to CSC. This is an important one to bear in mind. You don't want to make this mistake that was made in this referral. This was a patient, this is the picture of the patient referred with chronic central serous chorioretinopathy. And as it now goes, you already get the OCT, and you have a lot of patients. You want to hurry up, and you don't have all the time to look into the fundus. But oops, here you can see that there was no leakage in the macula downwards, but there was something going up there and leaking into the macula. And then when you did fundoscopy, you saw a small melanoma. You really don't have to, you really shouldn't forget fundoscopy, because then you're making a very big mistake in this case. When we did a Euretinian plaque brachytherapy in this case. So tumors. Osteoma is also something you can think about, and metastases, but think about nevi and melanomas. Then the sixth category is hematological malignancies. They are rare. They are often easy to differentiate. There's often history of the disease. This is a patient with Waldenström disease. You can do whatever you want, but the macular fluid will not go away. So it's therapy resistant, and it's probably because the antibodies, they accumulate in this supraretinal pocket, and they attract the fluid. Paraneoplastic syndromes, very rare. Benign diffuse uveal melanocytic proliferation, very rare, very easy to differentiate in general. Genetic diseases, they can present with CSC-like bilateral phenotypes. So if do an autofluorescence, if you have the machine, ask for the family history, because many of these are actually autosomal dominant. But I have seen referrals of supposed chronic CSC. They have a thin choroid, pseudoxanthoma elasticum. It's not super rare. It's recessive, so it's a single patient, often in the family. But these patients have a thin choroid. If there's a thin choroid, it's virtually never CSC. This is also one I want to highlight a bit. This is the ninth category. This is a psychiatrist in her mid-40s, and she was referred as a potential CSC. And this was the horizontal scan. And what immediately strikes you if you take a good close look, of course, there's serous fluid, there are some RPE bumps, but there's a thin choroid. That's unlikely in a typical CSC. But when you did a vertical scan, and that's the key here, you saw that there was this scleral bump. And this is a dome-shaped macula. So there's a scleral protuberation. There is a problem with the outflow of the choroid. And that's probably the cause for the supraretinal fluid. And why is that important? They don't respond to any treatment, in my experience, anything. So I asked the patient, I have some patients in which I tried everything because they wanted me to try everything, and nothing worked. Here you see also that the FFA could be suggestive of some chronic CSC, but the ICGA is very different. You don't see this mid-phase indistinct hyperfluorescence. There's another case. Serous fluid. Could be CSC, right? The choroid is not very thin. There are some thickened Haller's and Sattler layer vessels, RPE changes. But if you take a close look on fundoscopy 2, I'll show you later, the vertical scan, there is this kind of well, what is it? It's a kind of an inferior staphyloma. So this is the upper part. This is the lower part. There's a staphyloma inferior, and at the edge of the thickened and thinned choroid, because of the difference in eye form, there are RPE changes, and there's supraretinal fluid. Why is this important? It doesn't respond to any treatment unless there is, for instance, a neovascularization. Here you see the FFA. Could be CSC maybe, but it isn't. ICGA is not typical, and on fundoscopy you see a depigmented lower part of the fundus. So ocular developmental disorders, but also think about optic disc pit. I've had several referrals of supposed CSC, which was an optic disc pit. Fluid also doesn't respond to medical treatment, and some others. Medication-related conditions, you can have, especially now with the new medication for oncological diseases, you have these, for instance, these MEK inhibitors. They can cause bilateral serous fluid. It's not a reason to stop the medication in general, because it tends to resolve spontaneously, but not in all cases. But that can cause an acute onset bilateral serous fluid condition. Popper's maculopathy, but it's often quite a small lesion. This is a no-brainer, I would say, a rhegmatogenous retinal detachment. I had some referrals of chronic, shallow rhegmatogenous retinal detachments, often in myopic patients, and myopia is very rare in central serous, but they turned out to be a retinal detachment which obviously needs surgical treatment. This is an easy one, the 12th category, retinal vascular diseases. And some of them are very easy, of course, diabetic macular edema and retinal venous occlusion, but think about pregnancy-related serous fluid and HELLP syndrome. So if you have a woman who might be pregnant or is pregnant with serous fluid, you should check the blood pressure because it can be preeclampsia or HELLP syndrome. Now, just to end, I want to show you this case because it was something that we observed in the clinic and in our experience hasn't been described before. This is a lady in her, was about 60 years old, who had vision loss, very gradual vision loss. What strikes here is that there is a complete absence of the RPE over a large stretch. There is a thick choroid, and there's serous fluid. Here you see the RPE is completely gone here. This is just Brooks membrane, it seems. This was the FFA. There were some choroidal folds. There was some pooling in the late phase. Unfortunately, it was not the spectralis FFA or ICGA. You see, the ICGA is more diffuse if it's not a confocal system. That's why I'm such a big fan of confocal imaging systems. But there was some choroidal, well, there was quite a crowded choroid. And her vision stayed stable for many, many years. The other eye did have neovascularization eventually, but this was stable, the vision, 20/30 for many years, which is, I think, very striking because there's an absence of RPE and serous fluid for such a long time. To the best of our knowledge, this wasn't described before, and we called this serous maculopathy with absent RPE for lack of a better name. So we described it recently, which is also available open access, but it's rare, it's quite rare. Here's another one. This is a boy of 18-year-old, and what was so striking here, he had serous fluid, and he had this kind of thickening of the inner choroid. It was like there was a thickening of the choroid capillaris and maybe the superficial layer below. RPE changes. Vision was 20/20, and the other eye was 25/20. And there was no clear scleral perturbation, so there was no dome-shaped macula or whatever, no tilted disc or whatever. And the other eye was normal. And then there were some really marked hyperpigmentations. There was some focal leakage. It was also striking there would seem to be some kind of fibrotic process in this lower part, but there was no evidence of osteoma or whatever, or unpigmented nevus. So ICGA was not very remarkable. And we also didn't know what this was. It wasn't described before, to the best of our knowledge. So we called this, we first called this atypical serous maculopathy with atypical choroidopathy. And we presented, it was quite funny, we presented just one case in this paper, just one image. And then some other people saw, hey, I saw this before, and I also didn't know what it was. And then we combined all the cases, and it turned out that serous fluid in this case is quite rare, but that this is not that uncommon. And so we changed the name together with a group of Bailey-Freund to stellate multiform amylonotic choroidopathy. Probably very rare, but yeah, that's something you bump into. So this is the last miscellaneous category. Also think about drusen-associated serous fluid, because there can be extensive drusen without neovascularization, but the RPE will be so sick that it cannot pump away the fluid, and you will get serous fluid then. But it has a high risk of progression, of course. So in conclusion for this talk, due to the unique anatomical and functional characteristics, the macula is especially vulnerable for accumulation of subretinal fluid. The visual acuity can still be quite good, despite several years of fluid. Differential diagnosis can be challenging, but based on basic clinical examinations, you can, in virtually all cases, already make a good differentiation. And these different entities can be distinguished through a normal standard clinical examination. Sometimes you need FFA or ICGA or autofluorescence, but fundoscopy is already very meaningful together with OCT. And these differentiations can be very important for the clinical consequences and prognosis. So again, if you want to read more, this is the paper where you can dive more a bit deeper. And with that, I thank you for the attention for this talk. And if you want to go to the Ukraine Support Symposium this Friday, you're most welcome. We have a few minutes for interim discussion. In our experience, we get most questions based on the treatment talk, so I think we want to have a bit more room for the discussion at the end, but we can address some questions if there are questions about the differential diagnosis talk.
Hi. Thank you, Professor Boone, for this marvelous presentation. As you show some pictures of in the 9th category, dome-shaped macula.
Yes.
We have some patients with serious fluid accumulation, but flat irregular RPE changes as well. And of your patients, of the second patient of you already saw us that the patient had some flat irregular changes in the RPE.
Yeah.
How much time did you saw some neovascularization of these patients, or should we do some OCTA for these patients to differentiate this pathology? Thank you.
I think that's a very good point. You should definitely think about CNV. Everything that happens at the Brooks RPE interface can cause MNV. So in this case, there wasn't any MNV. We tried all kinds of anti-VEGFs and they didn't work. But definitely it's something to look out for because then you could treat. But in most of these tilted disc inferior staphylomas patients, it's really the problem with at the edge of the choroidal changes. So there's some kind of flow problem. You don't address that with anti-VEGFs.
And then maybe one question that has been sent in using the Q&A. That's what are you thinking about the multimodal imaging-based classification of CSC, and do you implement that in your routine practice? I think that's a really good question. So the basic classification, acute versus chronic, is mainly based on the duration of disease and also on the OCT scan. But we are working towards a new classification. We've already published one paper in that. And it's indeed important also